Pain, that medically elusive evil. What about changing the focus from controlling pain to understanding pain is more than a symptom? Can pain be cheated? My name is Dr. Dean, chiropractor and physiotherapist. My goal is to reframe how medicine understands pain to improve care. This podcast series is dedicated to a same-day conservative treatment for low back pain. This podcast has a companion published article, number 39. Welcome to the Pain is Not the Only Problem podcast. Article 39. Pain is not the only problem. Low back pain lifestyle co-contributors. These articles intend to reevaluate the prevailing clinical practices thought to manage low back pain, submit and debate novel low back pain contributors and mechanisms, meet patient expectations and satisfaction and clinically meaningful results, recommend a conservative non-surgical course of care to override pain instantly, and restore ADLs and patient confidence on the first visit at low cost. Since patient lifestyle choices are the commonest contributor to low back pain, it is prudent for the clinician to discuss co-contributors as well as faulty motor patterns within the reported findings. The following list is a collection of observed clinical informal findings. And I noticed that patients with low back pain were also sort of having these other non-clinical contributors. And actually, some of them were just so simple to solve. For example, I'll just give you the silliest one that I found is tight underwear. So we'll get to that pretty quickly. Anyway, they're not in order by preference or prevalence. It's just a very informal list. But I have 26 items here, and I sort of tried to categorize them a little bit. So I have a cheat sheet, actually, in my electronic records, and I just kind of put some of these different topics together so that I can kind of cruise through the whole thing in, a minute or two, just by getting sort of a yes/no out of the patient to sort of qualify if we should continue to talk about that topic. But this is a very detailed list because I wanted to explain that, yes, you've heard me say this a million times. Yes, you can see a disc herniation on an MRI, but you can't see that the patient is wearing tight underwear. But believe it or not, we'll talk about it coming up here. Anyway, of prevalence, however, is number one, and it's number one for a good reason. Smoking is the number one comorbid factor to low back pain. So if your patient's smoking, good luck treating their low back pain. And then I just wanted to add on that same topic that in my experience, all the comments I'm going to make on this particular podcast, on this article, are from my personal experience. I saw a patient who was experiencing post-surgical pain. So we would call that failed back surgery, which, there's no ICD code for failed back surgery. It's actually, I think it's medical misadventure. I'm not sure what the code is, but they're certainly not taking any accountability for back pain or surgical pain after surgery. The point of talking about that is that I had a patient had back pain after surgery, and their surgeon had no idea what to do next, and more surgery wasn't on the list. And so the problem is that the patient has been smoking since a teenager. So we're talking about a 60-ish year old patient, and smoked up to the day of surgery, and then smoked immediately after the surgery. So the problem is, and we don't know for sure, we know it's the number one comorbid factor. We don't know why. We can guess and say, well, it's probably causing systemic inflammation, or it's creating some sort of chemistry disruption that has related to nerve function or whatever that is. We don't know. But what we do know is that smoking can contribute to back pain or make it worse or delay healing. Number two. Now, I spent 21 years in Vermont, so this may not be as relevant to you in your area, but road conditions, potholes, rough roads, speed bumps, sudden stops, things like that jar the spine. If that's happening over and over and over, that can be a traumatic injury. And if your patient already has back pain and they are driving rough roads or making sudden stops, or they're like on the brake, on the gas, on the brake, on the gas, that could possibly contribute. Also, loose seatbelts that allow the driver to slouch, or these reclined deep car seats. If I have a low back pain patient, I'm going to go out into the parking lot, or if I'm doing a home visit, I'm going to go out in the driveway or into the garage, and I'm going to have them sit in their car seat so I can see how they sit in the seat. And I'm not going to do this with every single patient, but if I do this with a patient who's on the road a lot, they're doing a lot of commuting, or they've got the kids that they're transporting all over the place, and they're in and out of the car, it's actually, you know what? It's not always that they're in the car for a long time. It could also be in and out, and they're not paying attention to getting comfortably or properly seated in their car seat. So I'll take a gander at that and then recommend any sort of bolsters or positional changes to the seat, or how they manage their body position or their grip, or anything I can provide to help them with that. And then certainly, please don't let your patients reach their right arm around the back to the back seat. That's just a guarantee injury. And that's actually number 16. We'll talk about that. Okay, here we are. Number 3, the underwear story. Tight-fitting or high-waisted garments and belts. So let's talk about that. So this could be gym shorts, in my experience, or underwear. And I'm mostly talking about anything that's attaching around the waist with thin elastic bands, especially. So here's the story. So I had a patient with back pain, and he had gone to his primary and to referrals, and he didn't want to take drugs or pain pills or whatever, and he definitely didn't want surgery. So he came to me and he's like, so, what's the deal with my back pain? And I kind of already knew this. This is where I sort of had the epiphany. And I said, okay, so just undo your pant button and then go ahead and just pull your pants down just like an inch or two. I said, okay, I'm just going to take 2 fingers. I'm going to stick it underneath your underwear band, with their permission. I did that with this particular patient. I could barely get my fingers in there. And then I pulled it out, and the whole imprint, you could see the brand name of the underwear was woven into the elastic band. You could read the name of the underwear in this guy's skin because the underwear was so tight. And I said, this is really tight. And I think this is too small. And he said, oh, I've been wearing the same size since high school. And we'll talk about that again when we talk about footwear, right? Since forever wearing the same size shoe. So what happens is, there are cutaneous nerves, and then there are nerves for motor action. And these cutaneous nerves can produce this effect called neuralgia paresthetica. And it's typically down the lateral side of the leg or the thigh. But, it does get misinterpreted, or can occur with, or get confused for, whatever, this neuralgia with back pain. So I noticed this, and I noticed this myself. And so I had some pain, and it was like in my glutes, and it was like in my back. And it's like this neuralgia, or this cutaneous discomfort or pain, can be occurring with back pain that's being caused by another reason. So they're happening together. And so I noticed that if I was wearing underwear with a really wide, I found some with a 2-inch band, they're like athletic underwear. So if the band is wider and the underwear is, larger size. So I went from, believe it or not, an M to an XL, and it just changed everything. So I know this is ridiculous, but I buy underwear. This is particularly a problem with men. So I have underwear in my exam room that's new. It's still in the package, and it's all like L, XL, double XL. And so I go into the changing room, and I want you to put these on. And I usually jump up 2 sizes, right? So they come back into the exam room, and they're like, oh my God, these feel great. I can hardly feel them. Okay, so you shouldn't feel your underwear squeezing the life out of your waist, right? Turns out, now this didn't cure his low back pain, but certainly his symptoms were reduced on the spot. This has nothing to do with an MRI or an exam or referral, right? So this is something you can recommend, or in my office, I just do it on the spot because, I like to see the patient in their eyes when they have these aha moments. That's the underwear story. So wide bands and large underwear. Okay, number 4, plush seats or chairs, deep-seated sofas and couches, soft beds, water beds, God forbid, reclining chairs, right? So all of these can contribute to what I call the C, capital letter C, sitting shape. So, it's that classic upper cross, right, with a reverse lumbar curve, and they're basically sitting on the back of their lumbar, and their sacrum, right, is flat to the cushion. So the sacrum isn't against the back of the couch, it's on the cushion of the couch, right? And so they're sitting in this position watching TV, or they're reading or whatever. So yes, the C shape is sort of the observable situation, right? So you can just ask about that. Or sometimes I make a house call, or I'm doing some PT house call, and they have back pain. I'll say, hey, can I just check out your couch? Just, have a seat on the couch, get comfortable, show me how you watch TV or read, whatever. And then we can have this conversation. So it's not so much about the C shape, it's the fact that these plush seats and chairs and deep-seated sofas and couches and soft beds and water beds don't provide any support. So the patient just kind of, collapses into this squishy situation. I will recommend that they either switch out the couch, right, get a firmer couch, or switch out the cushions to something that's firmer. And, that can contribute to relieving some of their back pain. Now, we're only in number 4, but I'm just going to say, if you have a back pain patient and they've been having problems and they don't know what to do, and they are sitting on this soft couch and they wear tight underwear, and, their car seat is all in chillax mode, and they smoke, that's 4 things that can be observed, and you can have a conversation about that, right? So there's still 22 more. All right, number 5, long-term sitting, standing greater than 30 minutes without a movement break. So everybody knows this, but sometimes we forget to bring it up. There's no sacral motion, so that's the problem, is that the sacrum needs to go through that beautiful figure 8 over and over and over that only happens with this long stride walking, right? Heel strike, full gait cycle, full extension, right? So it's just standing and sitting. It's not so much that you're standing, it's not so much you're sitting, it's the absence of sacral motion. I'm just going to say it. I believe in it so much, this sacral motion. My low back pain patients, doesn't matter how horrible their back pain is, the first instruction on their take-home homework sheet is get up in the morning, already be dressed, go to bed in your gym clothes and socks, get out of the bed and put your shoes on and go for a walk right away. Not with the dog, just go for a walk. Nice, long stride, big arm swing. It's with or without pain. I don't care if it hurts. You're going to do it anyway, right? That's my number 1 go-to. So once we get that sacral motion established, then the spine has its marching orders for how to start dealing with stability and motor function and such. It's all based on the initiation of the day, the motor day, with sacral motion. Okay, number 6, exercising in the sagittal plane only. So we addressed that in article 23 or podcast 23. Chronic sagittal plane, sagittality. So everything happening, and there's no lateral bending, there's no rotation. We're talking about the spine primarily. Those planes of motion are absent, or they're just really small, or it's all like one-sided, like just reaching always with the right foot, always, turning right, whatever that is that's happening, always stepping on the first stair with the right foot, always pumping the spinning bike down with the right foot to pop out of the seat. The absence of full planes of motion, and that's been discussed over and over. Why do we care about number 6, sagittal plane? Well, if you just say to your patient, or you look at the intake form and it says, they check the mark, I do 30 minutes of exercise a day, and it's all in the sagittal plane, then that's a contributor to low back pain. It should be addressed. So what are they doing for exercise in the other planes of motion? Or, I go to the gym 3 days a week and I work really, really hard. And so you don't ask about it. It turns out every single exercise they're doing is in the sagittal plane. There's no lateral movement. There's no rotation. All that is missing. So that's a key. Number 7, exercises that require lying down or sitting. So why do we care about that? We don't care because they're sitting. We care because there's no ground force reaction. There's no loading through the calcaneus. There's no sequencing of the core. And so obviously there's not going to be any core activation. The core is quiet all day. So if you go to the gym and you lay down on the floor and you do crunches, you have no ground force reaction. Then you go to the bench press and you lay down again. There's no ground force reaction. You go to the leg press and you lay down, right? It's just all this laying down. There's no ground force reaction. Ground force reaction is the first cue for sequencing to produce core activation. And then sitting. So all the exercises in the gym have seats for some strange reasons. If we don't sit enough. So if you're going to do a lat pull, just don't sit. If you're going to do a chest or pec deck, whatever that is, chest fly machine, just don't sit. Figure out how to get into core neutral. Standing, right? That's ground force reaction. You're going to notice you're going to be a lot stronger. But the point here is that on the chest fly machine without sitting, I can do set of 30 repetitions of 350 pounds on one arm, multiple sets. So why can I do that? Not doesn't because I have big muscles, because I'm activating my core, and the core becomes the engine for my motion and not sitting down. So you sit down, the core gets turned off. All right, so no more lying down, no more sitting down. Exercising by body part. Number 8. Why do we care about this? So, I exercise 30 minutes a day, 5 days a week. And then the clinician stops talking. They're like, okay, check. Okay, you're exercising. All done talking about that. Well, but if it's broken down like by body part, like leg day, back day, arm day, whatever that is, abs day, that's a problem because there's no sling activation. So the upper and lower body and the right left body have to be all exercising at the same time in order for those myofascial slings to be activated from upper body across the core to lower body, and from left side of the body or right side of the body across the core to the other side of the body. And we've already discussed this. They're like, leg day. Well, then leg day is not happening again for another week. If you're doing just leg day, then how are you getting the upper body activated on leg day? And so there's no sling activation. So again, there's no core activation. So that's a problem. If there's no core activation, how the heck are you going to produce spinal stability? So number 7 and number 8 are a focus on spinal stability. Number 9, walking, jogging, running on a motorized treadmill. Please don't. So there's no hamstring contribution and there's no toe off. You're training everything underneath your pelvis and including your pelvis to function with only half of the muscles working, which are the muscles in the front. At my campus here, I have non-motorized treadmills. They're absolutely amazing. There's also this huge requirement to be, stabilize your body and not fall down because you're the motor, again, on that type of a treadmill. So the point here is with this gait cycle, walking, running, jogging, doesn't matter, on a motorized treadmill, is that there's no hamstring contribution, there's no hamstring activation, and so that's a problem. And that could contribute to back pain. So here we are on 10, we're going to talk about spinning or spin cycling or stationary cycling. Make sure I'm not infringing on someone's trademark. So we're going to talk about this because there's this reduced hip active range of motion. The hip flexors only go through an inch or two of a range of motion, and they have a huge range of motion, almost 180 degrees. So we're going to be, only using like 5 degrees over and 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 over 136 times per minute for 50 minutes, right? Over and over in this teeny little range of motion. So that's a problem because it's, attached hip flexors, it's attached to the spine. Also, there's no heel strike. So you're teaching a gait motion that has no heel strike and there's no push off. And so that's a problem because, again, the myofascial slings aren't being activated. And so there's no ground force reaction. So there's no core activation again. I feel like I'm talking about this, I can't remember, some movie where it didn't matter what they said, it all came back to, it was Blade Runner, Rutger Hauer, and he was trying to figure out a way to not die at 4 years. And he's like, well, you could do this. And so, it was like, no, that isn't going to work. And he's like, well, what about this? No, that isn't going to work, right? So I feel like whenever I talk about all these things, I say, it's like, doesn't matter what you do. If it doesn't land in core activation, you need to re-examine what you're doing. It needs to be modified and improved so that you actually get core activation, which is more work usually, but it's worth it. So again, about the cycling is it's a narrow fixed foot base. I think it's like 9 inches apart. And, classically core neutral is wider than hip width foot base. So you're teaching that shallowness. So now you're back to chronic adduction, adduction, which highly influences the base of the spine. And of course, on these spin cycles or indoor cycles or whatever you want to call them, there's no balancing because the feet of the bike are doing all the balancing for you. So that's a problem. And then I mentioned before, typically, I'm going to say 99% of the time, the teacher is going to have you jump out of the saddle, going to automatically push down like on your right or your dominant foot. You have a great spin teacher, they're going to say, don't forget, you need to jump out of the seat. Make sure you're pushing down with your left foot. Number 11, ellipticals. Yes, we're going to pick on exercise equipment. So again, the problem is reduced gait, just like the spin. It's a narrow or fixed foot base. It's usually about 9 inches apart. Might be 11 inches, which is still at least 50% too narrow. And then the stride length is usually about 14 or 16 inches. And I know mine is more like 30. The problem with the elliptical, it's the opposite problem of the motorized treadmill. This one eliminates hip flexion and plantar flexion. That's eliminated, whereas in the motorized treadmill, it's eliminating hamstring. So you can't just go half the time on the treadmill and half the time on the elliptical and fix that problem. You need to get off of both of those and occasionally spin, which I'm not going to be bad on spinning because I love it. The other complaint about the elliptical is that people's feet fall asleep, right? So why are you doing something, an exercise that's attempting to improve your health if it's making part of your body fall asleep? I'm just going to say no elliptical, zero elliptical. And then, I would think about using a rower, a good rower like the Concept 2 rower. Don't waste your money on anything else. Number 12, one-sided acceleration sports. Means that there's a quick movement, and it's always on one side of the body, chronically on one side of the body. Perfect example is like tennis and golf. Now, I'm not going to be bad on tennis. I'm not going to be bad on golf. All these one-sided accelerating sports, I'm not going to say stop doing it. I'm just going to say when they're training, you train bilaterally, and then just when you do your application, make sure you are just doing the side that you prefer. So I train for tennis, left side and right sided strokes. So I'm getting double training, and then that's my training. And then the application of my training is just primarily on the right side. Now, what happens when I got, like an elbow injury, not from banged my elbow on something. I think it was on my car door. And I was like, oh, great. And I have to teach today. Well, oops, I forgot. I'll just switch to the left side. No problem. It's not that, they're bad. One-sided sports are bad. I'm just saying that they can contribute to low back pain, especially if there are other contributors from the list that you're noting. So 13 is dehydration, diuretics from caffeine, low mineral content water, distilled water. I know people just drink distilled water, and it's just really no bueno. And then I'm just going to say here, my quick little jab at alkalized water. That's with an ED. So that's man-made. That's a problem because they use heavy metals to add those extra ions, and you don't need those extra ions. Nothing magic about alkaline or alkalized water. Please don't drink it. Okay, now alkaline water occurs naturally, especially if the bottle says naturally acquired from a aquifer or a well or wherever they're getting it from. It's occurring in nature. Okay, so the human body does not need alkaline profile of water. It doesn't matter what you put in your body's always going to go back to its homeostatic baseline. There's nothing you can put in your body that's going to switch the proton distribution about your body. And I'm going to do a podcast specifically on this alkaline water thing because it just needs to be discussed and people need to understand what they're doing to their bodies. So Okay, so why do we care about dehydration, caffeine, and low mineral content water? Well, because this affects the electrical balance in your body. So you need to have water to provide ions for all sorts of things to happen in the body. And of course, water is, the primary ingredient in the human body. So you want to make sure that you're not getting your water from caffeine or from soda, drinking plenty of water in your day. Okay, everybody knows that. Number 14, saunas, hot tubs, heating pads, will overheat already inflamed discs. So I have a friend who had back pain and he bought a hot tub and he got in the hot tub and it made his back pain worse. If you have a hot back injury of some kind, right, could be undiagnosed, but just don't use heat. Number 15, very interesting, shoulder bags and handheld briefcases, especially when they asymmetrically load the spine and maybe cause a little shoulder elevation. Now, you wouldn't think that, why are we looking up at the upper body and not focusing on back pain? Well, because shoulder bags and anything that loads the spine at the top is going to load the whole spine and even down to the knees and that ankle mortise joint. So your patient shows up and they have their keys and their phone. So you need to ask about this because they may not bring their bag in. Or some people bring those, rollerball type wheel bags everywhere they go and they're dragging it behind them, right? So they're always twisted and they're always extended. And remember, I'm not saying a shoulder bag is going to cause back pain. I'm just saying that it could be a co-contributor along with an injury of some kind in the back. Number 16, trunk flexion plus twisting plus lifting, right? So this is the classic reaching into the back of the trunk of the car while you're rotating and you're reaching for a bag and it's kind of far away and you kind of have to twist and pick it up. If they're doing this, or they may have done it and it may be like an incidental trauma. Have you recently tried to pick up something and were you twisting and reaching at the same time? Oh yeah, I totally forgot about that. I was taking my luggage out of the back of the car or the back of the seat or something. So I bring this up because yes, it happens when you're picking up your bag, but commonly this is the way people also get out of their bed. This same combination. In my case, I just installed a little bar, a little grip, and I use the grip and I jump out of bed and I'm all happy. There's nothing worse than getting out of bed and immediately stirring up, your back pain before you even put your foot on the floor. So one of the things we say is, do you have back pain upon rising out of your bed, right? Don't we ask that? Not because you're getting out of your bed, it's how you're getting out of your bed. So yeah, think about that. Okay, 17. So 17, 18, and 19 all are kind of go together, but I'm going to break them apart so you'll understand them individually. 17 is inflammatory foods, just food. So we're talking about things that will cause inflammation in the body themselves. The ingredients cause inflammation. Energy drinks, caffeine, juice, alcohol, anything grain products, beer, pasta, any of that, meat, fat, and high sodium. All that and many, 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 many other things are foods that when you stick it in your mouth, it goes in your body responds, and you get inflamed. Okay? Now, there's another group. This is 18. This is histamine producing foods. Now, these foods don't start off producing histamines that lead to inflammation. They do over time. The first one is condiments. I could do a whole podcast on condiments. Sometimes I'm in the patient's house or, I ask them or I have them take a picture, or believe it or not, I've asked patients on their first encounter, can you just grab like 5 things out of the door of your refrigerator? They're condiments, and put them in a bag and bring them in. And they think I'm crazy. Then we talk about histamine producing foods. They're like, oh yeah, I can change that. No problem. And then for some reason, they don't have as much back pain, right? So I'm just saying it's co-contributors. Condiments have an expiration date. That's not the day they go bad, right? That's how long they last with the lid on it and you never opened it. When you put condiments, you open up, you put it in your refrigerator, it's got like 3 months and you got to throw it away. My experience, people with condiments, there's past the expiration date of 5 years and still in their refrigerator. So there's nothing magic about a condiment, why it gets to stay in your refrigerator any longer than a tuna fish sandwich. right? Doesn't matter. You can stuff the tuna fish sandwich in a jar and put a lid on it. It doesn't matter. You can even make it airtight. It isn't going to last. Certain condiments with higher salt content might last a little bit longer, but you need to date your condiments. And if you don't remember when you opened it, you need to throw it away. Condiments are cheap. You can get, a mustard for 79 cents. Now, if you open up a condiment, I feel like I want teriyaki chicken. And you're like, I have to open up the whole thing, right? And once I open it up, Dr. Dean's like, oh, you've got 3 months, you got to throw it out. And I don't think I'm going to make teriyaki chicken again. You need to think about using condiments that you're willing to pay, $1.79 or whatever it is. I'm going to open up the teriyaki sauce. I'm going to use it. And then if I don't use it again in a month, I'm going to pitch it. Right, just throw it out, even though it's totally full and you only used it once. It's cheap, right? But don't make yourself sick with old condiments. It's just not worth it. Next one is sardines. Now, sardines aren't bad, but, they're old. They've been in a can for a long time. Now, it's not talking about the cans open or closed. I'm just saying they've been in a can a long time. Sardines are super healthy, omegas, calcium, protein, all that, delicious goodness that you get from sardines. Like, I'm a big fan of sardines, but you just have to remember that they're in their little can producing histamines tick, 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 tick over time. Don't wait until the expiration date. Buy sardines with the earliest expiration date. Okay, and then we're going to talk about, same topic, histamine producing foods, countertop foods. So what do I mean by that? So I mean anything that you're leaving out, fruit, bread, pie, last night's dinner, pizza, in the pizza box, like, oh, I'm just going to have it in the morning. I'll just leave it on the countertop. Don't do that. All these foods that you're leaving out are producing histamines. And the histamine count is increasing, tick, 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 as the longer they sit out on your counter. There's no reason. Now, I'm not saying just stick it in the cupboard. Keep your bread in the refrigerator. Keep your fruit in the refrigerator. There should be no food out anywhere, not even nuts, nothing. Just put it in the refrigerator. Part of why I make a big point about this, I had a patient with this horrible gut dysbiosis, been following her around her whole life. And somebody's trying to tell her she has Crohn's. Someone's trying to tell her she has gastrointestinal complications. She's got GERD. She's got, inflammatory bowel disease. She doesn't have any of that. What she has is an ongoing conveyor belt of histamines going into her body, right? And that's why it's been following her around her whole life. So you have to look at patient habits. You can't just point your pencil eraser at an MRI and get all excited because there's a disc herniation. Then you need to turn to the patient and say, do you leave your bread out on your countertop? I bring up this story because she had this problem, and so it just happened that she made me dinner. So I went to her house, and we had a nice big family dinner. Doctors coming to dinner. And it was a pot roast with onions and all my favorite stuff, carrots and potatoes. And then after, I was cleaning up, in the kitchen, because I like to clean up. I was so, okay, so what are we going to do with this? She said, oh, I just leave it out overnight. And I said, what? She says, yeah, I've always done that. My family's always done that. We just leave it out overnight. I'll put it in the morning. And I said, but that's what's making you sick. You can't leave this out overnight. And it's not so much about the bacteria. It's more about that it's accumulating histamines. She's got her avocados out, her fruit out. Leaves the cheese out, the butter out, like everything's out, right? And they've been doing that their whole life. So I was like, no, I'm putting it in the refrigerator. So I packaged it all up, put it in little containers, opened up the refrigerator door, and I couldn't believe there's like 3 months worth of food all jammed in there, all rotting in the refrigerator. You can't eat that. It's just, well, yeah, I probably can salvage some of it. And I said, look, you can't always be eating old food. You need to eat new food, right? So the point here is if you have a patient that's always eating leftovers and they're always eating, food that's been in the refrigerator for 5-6 days, meat only lasts in the refrigerator 2-3 days. So, and I don't care if it's lunch meat. It's accumulating histamines. It's not because of the mold. It's not because of the bacteria. It's because of the histamines. If you go out to eat, go to a sandwich place, all that food's sitting out. So it's accumulating histamines day and night. And then also alcohol, of course, leftovers. And I've already talked about deli meats. I could do a whole show just on deli meat. Just pretend like it doesn't exist. The third of the trio of 17 inflammatory food, 18 histamine producing foods, and 19 now is low ORAC foods, ORAC. So low ORAC value foods. Why do we care about that? ORAC value is kind of a real thing. It's kind of not, but let's call it a guide. So basically we're talking about eliminating oxidative reactive species in the metabolism in the bloodstream. So we're talking about highly oxidating, causing oxidation in the tissues, which causes tissue damage, right? So what we want are foods that have low oxidative species in them or oxidative reactive species. And we want foods that are antioxidating foods, right? So that's how you say antioxidant. That's what we're talking about is this ORAC, the ORAC value foods. So high ORAC value foods. Now, what is that? Well, there's a whole list of them. Cinnamon, rosemary, a lot of the Mediterranean herbs, blueberries, things like that. You know what that list is, right? So trying to get a lot of those things. If it's mostly low ORAC foods like hamburger or cheese and mayonnaise and bread, right? Well, that was your lunch. So it was all these low ORAC. So you're just accumulating all this oxidation in the body. And then you've got these, histamine pumping countertop foods or your, old bread. And then, you're eating inflammatory foods. You chug a Diet Coke with it. You're doomed, right? So all of this is responsible for systemic inflammation, which delay healing or make symptoms worse. The next one is delay in bladder and bowel emptying. So it's like holding due to lifestyle or being overbooked, right? You never make it to the can. So that's a problem because that's a contributor to making your body tight, like the holding, the delay in the emptying. You're making your body tight and holding. And that can be a confusing motor command to your lower back. So make sure you're not holding your bladder or your poop. Like just go. Number 21, slouching or upper cross syndrome. So this is what we were talking about before when we were talking about plush seats. What I'm talking about here is stand slouching or whatever, looking down like at your phone and all that business, or just looking down for no reason. So look up. So that's a contributor, is that upper cross syndrome, but low back complaint. Clinically, I don't think the exam is going to look at upper cross syndrome. I've been to several surgical consults for low back pain for me personally. Nobody ever addressed much less lower cross syndrome than upper cross syndrome. But I'm just saying, don't forget to look up. Number 22, so we're going to go back to footwear. So this is wearing flip-flops, slip-on shoes, clogs as primary footwear, and not wearing lace-up shoes. So why do we care about this? Okay, so the joke is that flip-flops, actually a way of interpreting why are they called flip-flops. Well, in my world, they're called flip-flops because they flip-flop how the gait cycle works. So you're not doing heel strike, toe off. The heel's not coming up and back. There's no step over. So it's a backwards, mismanaged, flip-flopped gait cycle. So what we're talking about here is unsupportive footwear, high heels, especially like those crocodile shoes, those plastic crocodile shoes with the big holes in them that you can stick the junk in. Yeah, so all that slip-on stuff is preventing natural gait cycle. And if you wear that all day, I was actually waiting for a nerve conduction test, sitting in the lobby. Every single medical provider that walked past me was wearing those slip-on plastic crocodile footwear. They weren't paying attention to their quality of footwear. So you definitely need lace-up shoes in your day if you're going to be walking. If you're not walking, you just be barefoot. And then related is 23, which is flat-footedness or pes planus that's been uncorrected. In my office, it takes about 1 minute to correct that. And so the problem is that it's changing the gait cycle, which is changing or eliminating the possibility of core recruitment. It completely screws up everything, the knee, the acetabulum, PFJ, everything. PFJ, pelvic femoral joint. Shoes worn that are too small. When I was a kid, I worked in a Red Wing shoe store, which is so much fun. These guys would come in to get their new Red Wings, and they would say, oh, I take an 8EE, right? And it's like, but they don't want to take their foot out and have you measure their foot. So the thing is, over time, the shoe size changes. The foot size changes. And so, like, oh, I've been wearing 8EE forever. It's not going to change. But so what's happening is the wrong or less information, and the information being read at the bottom of the foot proprioceptively is basically, toes all crammed together. So there's that. And then there's also this thing that's trendy now, is wearing shoes that are too big. So I notice, mostly guys in the gym, they're wearing their high tops and they're just gigantically big. So I just think it's trendy. And then, of course, they don't lace them up to wear just big, giant shoes. I don't know. I heard a story sometimes, the size of your shoe is correlated to something. So the problem is, like, guys who should be wearing like an 11 or 10 and a half are wearing a 13. And then this other thing, so since we're talking about shoes, is lacing medially. And so what I mean is the bow tie of the shoe is on the inside of the shoe, or to being tied kind of facing each other. And so clinically, what does that mean, or why is that important? Well, it means that your patient can't bend over to tie their shoe. So what they're doing is they're taking their foot and placing it up on the other knee and tying their shoe, right? So the bow ties are going to be on the inside or the upside of the shoe once it's flipped over onto the opposite leg. So when your patient comes in and the shoes are tied medially, you don't even have to ask them to bend over and touch their toes. And then 24, which is super important, which is fear or anger of perpetuated low back symptoms. So there's actually good research on this that says that fear of pain never resolving is a huge contributor to persistent low back pain. If you could just, use that clinically, I just tell my patients, don't worry, you're in good hands. This pain is totally within my wheelhouse. You're going to feel a lot better today. Personally promise you, you're going to feel a lot better today before you even leave my office. And that's what I say, and I'm not afraid to say it. 25, patient disinterest in resolving their problem, blaming their caregiver, non-ownership to participate. We're talking about low back pain co-contributors. How's that a co-contributor? Well, if your patient isn't interested in being part of the solution, like being their own best doctor, then they're never going to get better. If their back pain is always somebody else's responsibility, patients come in and like, what, can you help me? Yeah, I can help you. Well, what are you going to do for me? Well, it's not what I'm going to do. There's a level of patient education that's going to be happening so that you can understand what's going on here. Not just understanding, that you're in pain. I need you to be on the team with me. We're going to work together on this. It's definitely a team effort, and the team can win. Remember game day, if we do this together. So that's when I tell them that I'm totally committed to making sure that they get what they need, but it's a 90-20 or 110 split. You give 100% and I'll give 10%. You give 90%, I'll give 20%. Any way you slice it, we're all giving 110%, not 100%. And then finally, 26, sympathetic lifestyle. So actually the next two podcasts or articles, 40 and 41, deal with sympathetic and parasympathetic lifestyle. And just quickly, sympathetic lifestyle is that sort of amplified existence of racing around all the time and taking too many calls and overbooking, overpromising, eating fast food, always being on the verge of tears, anger reactions, taking care of others to control how they think about you without taking care of yourself first, that kind of stuff. So the point of all of this list is to let you know that there are other things out there that clinically can be valuable to you if you ask the right questions. So when I do this, I kind of group things together. Like I'll talk about feet and shoes and walking all together. I'll talk about exercise machines and cardio activity all together. I talk about food all together, talk about bags, the shoulder bags and things, slouching and upper cross, talk about all that together. So I kind of lump these things together. And honestly, it only 2 to 3 minutes maybe to go through like all 26 of these. And there might be some little pearls in here. And all of these things are things that can be managed clinically right on the spot. either with, verbally or with a handout or a video, or, I'm planning on producing a bunch of YouTubes. So if you want to just send your patient to the YouTube on these topics. It's not about overwhelming them with do this, don't eat sardines and don't drink coffee and stop exercising on the elliptical and buy new furniture and make sure the roads don't have speed bumps. That's not what I mean. It's you being able to say, hey, I want to manage this low back pain as effectively and efficiently as I can. A key on some of the things that are probably happening in my patient's life that are just persisting to complicate the treatment plan. Well, why wouldn't I address these? And so the reverse story of this, of course, is no active care. There's no orthopedic examination except for Gainsland's and piriformis test and Trendelenburg and whatever that is, those, orthopedics. They don't do anything functional. There's no spinal stability. There's no acceleration, deceleration, none of that kind of stuff, right? So it goes from, hi, I'm here to help you. What can I help you with today? Oh, I have low back pain. Oh, okay. So touch your toes. Can you twist left, twist right? Okay, lay down on the table. You lift up their leg. Does that hurt? Right, straight leg raise. Oh, does that hurt? Okay. So I'm going to get an x-ray and I'm going to send you for a surgical consult, right? You never ask any of these questions. So the problem is now this person's in front of surgery, right? And it seems so impressive, right? Because it's just, oh my God, someone's going to hack into my body and they just love me and they know what they're doing. And there's this idea that there's a guarantee that they're going to get better, but there's, definitely no guarantee. And you sign your life away. There's no promise and nobody's feet are held to the fire if it doesn't work. You're at that point on the table. And the question is the surgery going to fix any of these 26 things I just mentioned? Is the surgery somehow going to make the smoking thing go away? Or is it going to change how they exercise? It doesn't matter if you do surgery. They're doing 26 things anti-low back pain recovery. And they're doing these every day, all day long. So I'm talking about little one-ofs. I'm talking all these things here are things that are perpetuated in the average patient's life every single day, day in, day out, and while they sleep. So surgery can't compete with this list. It's impossible. And it's not going to correct any of these things. So we're talking about novel approach. We're talking about, benefiting the patient, and all this whole conversation of all these things, these 26 things, it's taken me an hour to tell you about. It only takes 2 to 3 minutes to talk to the patient about. That can be done on the first encounter and at low cost. Plenty of time in your E&M, code appropriately for your extra 2 to 3 minutes, even if it's 5 minutes. As usual, thank you for joining me today. Let's advocate for improved patient satisfaction and for the profession. Let's all demonstrate a universal, loving, cross-culture willingness to strengthen medicine. Thank you.